The next case we are going to present to you is a 67-year-old male patient with a history of visceral Leishmaniasis. Imaging studies found a cystic lesion between the duodenal bulb and the pancreatic head. The red arrow on the right image indicates the cystic lesion found on MRI, and Professor Napoleon is now going to perform the EUS in that case.
10 minutes?
Yeah, 5 minutes. Okay, we're on.
That's okay? Okay. You saw the case, so perfect.
Yes.
I can go on. So we must do a bit quickly. So you see here the head of the pancreas. I'm in the second duodenum, and I'm looking for this cyst. We saw the common bile duct, which seems to be normal, not dilated. I progressively withdrawing the endoscope in order to evidence where should be the cyst. For the moment, we see nothing in the head of the pancreas. And progressively, you see the appearing cyst, which is there. It looks like we could see it better from the bulb. Yes, you see it now, a big portion of this cyst, which you see is very unusual with a lot of septas. It seems very smooth, easy to depress, a lot of cystic spaces. And one important point is that it seems to be not fixed, you see. We are now, at the beginning of the examination, you didn't see, we were up on the head of the pancreas, and you see that now we are even closer to the isthmus or the body of the pancreas. That's a very important point, because it means that it's not a cyst inside the pancreas, but around the pancreas. And if you consider that, the etiology of the cystic lesions with such numerous spaces, moving, easily depressed, sometimes with fine calcifications in the walls, it is frequently or a mesenteric cyst or a cystic lymphangioma. And we talk about that with Rob before seeing. Having the life, and it seems for us the most probable etiology. You see here and now progressively withdrawing the endoscope. I have no more. You see the pancreas, which is there, body of the pancreas. You have the usual aspect through the stomach, and you see that the cyst is really external to the pancreas. It's up on the level of the head. It is certainly close to the head. To the head, but not originating from the head. So, in our opinion, it's of course a benign cyst. You see that there is nothing inside the spaces, no vegetations, no mural nodules, no tissue around it. So it is outside of the pancreas, and we were discussing about FNA, but we think that in this situation, FNA will probably will not add any information, and we could have some risk of infection. So we were not in favor to do an FNA in this situation.
So Mike, I think we're needing to rush off here pretty quick so that we can join you this evening. But I think in summary, we think that this is either a mesenteric or a lymphatic-based cyst because of the spaces. I think we could aspirate it, but I think it's important as a teaching point that just because you can do something doesn't necessarily mean that you should. And I think it's unlikely that the fluid that we would obtain would provide any unique factor that would allow us to make the differentiation. And there is some risk of infection. And so I think an interesting case. We should have put we did put, I think, a color flow Doppler on it. It does not have flow, but I think some type of a mesenteric or a lymphatic cyst is what we think is present.
And you see very early in this patient differentiation between the parenchyma, the pancreatic parenchyma, which is there, and when I remove the endoscope, there is no more parenchyma, and you can begin to see the cyst with those multiple spaces. So it really is outside the pancreas.
Beautiful image.
Okay.
Okay.
So
Thank you, Mike.